Now we go ahead with the second session. Dr. Suchit will start the session.
Good morning, everyone. The next session is going to be an interesting symposium on DSD. To chair this session, I am privileged to invite Professor Kenichi Kashimada, who is working as Associate Professor in the Tokyo Medical and Dental University, Japan. His areas of interest are embryonic medicine and pediatrics, metabolic and endocrinology, medical biochemistry, developmental biology, and molecular biology. And also, I'm privileged to invite Professor Vijay Lakshmi Bhatia, Professor, Department of Endocrinology, SGPGI Lucknow. She's having area of interest of bone and mineral metabolism.
Kenichi Kashimada from Tokyo, and the first talk about the symposium of DSD is genetics of DSD by Dr. Atsushi Hattori from Japan. So could you start your talk, please?
Thank you for the introduction. It is my great pleasure to speak at this symposium. I have no conflicts of interest to disclose. I am from the Department of Molecular Endocrinology at National Research Institute for Child Health and Development in Japan. Our research interests are broad, ranging from endocrine disorders to other congenital disorders. We are particularly interested in sex development, sexual maturation, and reproduction. Today's topic is sex development during the embryonic and fetal periods. Differences or disorders of sex development, abbreviated as DSD, are classified into sex chromosome DSD, 46XX DSD, and 46XY DSD. Most cases of 46XX DSD are attributed to 21-hydroxylase deficiency. In rare cases, 46XX individuals can exhibit testicular formation, a condition known as 46XX testicular ovotesticular DSD. 46XY DSD includes disorders of androgen biosynthesis, androgen insensitivity syndrome, and disorders of testicular development, such as gonadal dysgenesis and testicular regression syndrome. Today, I will focus on 46XX testicular ovotesticular DSD and 46XY DSD. In this presentation, I will begin with 46XY DSD. I will provide an overview of genetic etiologies, and then introduce DHX37, a gene recently recognized as responsible for 46XY DSD. And lastly, I will discuss the genetic etiologies of 46XX testicular ovotesticular DSD. And I will start with an overview of genetic etiologies of 46XY DSD. To date, more than 10 genetic screening studies on 46XY DSD have been reported. Among these, I will focus on 2 studies, both of which analyzed more than 200 individuals with 46XY DSD. One article on the left was published from Australia in 2016, and the other article on the right was published from Brazil in 2022. The major clinical diagnoses were gonadal dysgenesis and disorders of androgen biosynthesis or action in both studies. On these participants, next-generation sequencing using gene panels and/or exome sequencing was performed. Overall, the genetic diagnosis was established in 44% in the left study and 60% in the right study. And next, we will examine the results by the subgroups of DSD. And this slide summarizes the results of disorders of androgen biosynthesis or action. Overall, the genetic diagnostic rates in this subgroup are high, especially in the right study. More than 90% of cases achieved genetic diagnosis. The major responsible genes were AR and SRD5A2 in both studies. In contrast, the genetic diagnostic rates in gonadal dysgenesis is not so high, ranging from 30% to 40%. The major responsible genes included NR5A1, MAP3K1, SRY, and DHX37. Notably, DHX37 was not included in the left study because this gene was not recognized as responsible for 46XY DSD at this time. DHX37 was first reported as DSD responsible gene in 2019, and I will discuss this gene in more details in the next few slides. DHX37 is an ATP-dependent RNA helicase. It processes ribosomal RNA and contributes to ribosome biosynthesis. It has two Rec-A-like domains, which are critical for binding ATP and RNA. Almost all variants causing DSD are located within these two regions. Clinical manifestations are characterized by regression of Müllerian derivatives, and findings of external genitalia are diverse among cases. The patients receive a clinical diagnosis of testicular regression syndrome, gonadal dysgenesis, or 46XY DSD with clinically unspecified etiologies. Conventionally, testicular regression syndrome and gonadal dysgenesis were considered two distinct conditions. In the next slide, I will discuss our putative mechanism for why these two distinct conditions are caused by mutations in the same gene. In individuals with DHX37 variants, it is presumed that the testes are initially formed but regress afterwards. In the physiological, embryonic, and fetal sex development, the external genitalia are masculinized between 8 and 12 weeks of gestation by testosterone produced by Leydig cell and its metabolite dihydrotestosterone. And the Müllerian duct regression occurs between 7 weeks of gestation and 11 weeks of gestation by AMH produced by Sertoli cells. Therefore, if the testes regress after 12 weeks of gestation, when the external genitalia are fully masculinized, the clinical phenotype would be testicular regression syndrome. However, if the testes regress earlier, the external genitalia would not be sufficiently masculinized. The clinical phenotype would resemble gonadal dysgenesis. Importantly, in this gonadal dysgenesis-like phenotype caused by DHX37 variants, regression of the Mullerian ducts occurs. This is not our typical finding in gonadal dysgenesis due to other etiologies. This slide summarizes the DHX37 variants that were identified at our institution. 3 variants were identified in 4 patients. Patients 1 to 3 received a diagnosis of testicular regression syndrome, and patient 4 exhibited with gonadal dysgenesis-like phenotype. All 3 variants were previously reported pathogenic variants, and the affected residues were highly conserved across species from human to yeast and were located within the 2 critical regions, 2 REC-A-like domains. This slide summarizes the clinical findings of the 4 patients. The Mullerian derivatives were not observed or only rudimentary. The findings of the external genitalia were diverse among cases. As for gonads, patients 1 and 2 had streak gonads. In patient 3, the testes were palpable at the age of 2 years, but became unpalpable at the age of 33 years. This postnatal regression of the testes may raise a possibility of potential role of DHX37 in postnatal maintenance of the testes. In the last part of my presentation, I will discuss the genetic etiologies of 46XX testicular ovotesticular DSD. Although SRY translocation is identified in more than 90% of cases of 46XX testicular DSD, it is extremely challenging to establish a diagnosis in SRY negative cases. Although variants in more than 10 genes have been reported, variants in each gene are extremely rare, leaving most cases undiagnosed. Among these variants, I will focus on 2 variants in SOX9 and NR5A1, both of which are laboratory contributed to the discovery. NR5A1 is expressed in the developing gonads, activates transcription of SOX9, and promotes testicular development in 46XY gonads. Disruption of NR5A1 was conventionally known to cause 46XY gonadal dysgenesis, but not 46XX ovotesticular DSD. However, in 2016 and 17, 3 research groups, including ours, independently reported that the arginine 92 tryptophan variant in NR5A1 leads to 46XX ovotesticular DSD. At least 2 mechanisms have been proposed to underlie this testicular formation caused by this variant. The first hypothesis was proposed by Bachamboux and colleagues from France. Wild-type NR5A1 is known to interact with beta-catenin to activate transcription of NR0B1, which in turn represses the expression of SOX9. Bachamboux and colleagues showed that the arginine 92 tryptophan variant had a reduced capacity to activate transcription of NR0B1, thereby allowing SOX9 to be expressed at levels sufficient to initiate testicular development. The second hypothesis was proposed by Igarashi and colleagues from our lab. Wild-type NR5A1 is known to activate expression of SOX9. This transactivation of NR5A1 is repressed by NR0B1 in a dose-dependent manner. However, Igarashi and colleagues showed that the alginine 92-tryptophan variant escapes these repressive effects. These findings suggest that this variant activates transcription of SOX9 even in the presence of NR0B1 and promote testicular development in 46XX gonads. Although these two hypotheses are intriguing, the precise mechanism underlying the testicular formation induced by this variant remains to be investigated. Next, we move to SOX9 variants. Duplication upstream of SOX9 is a well-known etiology of 46XX ovotesticular DSD. To date, more than 10 such cases have been reported. In contrast, single nucleotide variants in SOX9 are well-known etiologies in 46XY DSD, but not in 46XX ovotesticular DSD. However, in 2021, Ushijima and colleagues from our lab reported the glutamate 50 lysine variant in a patient with 46XX ovotesticular DSD. They showed that this variant had an increased transactivation function on murine testis-specific enhancer of SOX9. Considering that SOX9 can activate its own genes, this increased transactivation function may lead to upregulation of SOX9 and induce testicular development in 46XX gonads. Here is the summary of this presentation. Regarding 46XY DSD, the genetic diagnostic rates in disorders of androgen biosynthesis or action are relatively high, and common responsible genes are AR and SRD5A2. In contrast, the genetic etiologies in gonadal dysgenesis are heterogeneous, and its diagnostic rates are not so high, ranging from 30 to 40%. DHX37 is a novel, important gene that is responsible for 46XY DSD, especially in individuals with absent or dysgenetic testes associated with Mullerian duct regression. Regarding 46XX testicular ovotesticular DSD, the etiologies of SRY negative cases are largely unknown, although several case reports have clarified the etiologies of limited number of patients. I would like to thank my colleagues and their collaborators for their hard work and their successful achievements. We are happy to collaborate internationally If you have any undiagnosed case of DSD or other disorders associated with gonadal functions, please do not hesitate to contact us. And lastly, I would like to thank the conference organizers for giving me the opportunity to speak at this honorable symposium. Thank you for your attention. I'm happy to answer any questions.
Thank you, Dr. Hattori. Very clearly, you overviewed the genetics of DSD and also very insight into the recently identified DHX337 and also the very unique missense variant about NR5A1 and SOX9. Also, sorry I forgot to introduce you briefly. He is one of the rising stars in our society, Japanese Society for Pediatric and Endocrinology. And he is now working at the Maki Fukami's lab. And so, yeah, thank you for your presentation.
Thank you very much.
And I also would like to inform you that the first two talks about the genetics of DSD and the latter two talks about genitoplasty of DSD and a little bit different. So if we have a time, I would like to have a discussion time after the first two talks. So thank you for your talk.
Thank you very much.
And I would like to move to the next talk. The Professor Girunda Sainto Prabhoff from Thailand, and she is the chief division of endocrinology and metabolism department of pediatrics and the Faculty of Medicine, Siraj Hospital, Manindal University. And she is contributed as APES as a council from 2016. And her talk is genotype and phenotype correlation in DSD cases. Gerunda, could you start your talk, please?
Thank you very much, Kenichi, for your kind introduction, and good morning, everyone. I work at the Siraj Hospital, and we established the intersect care team since 2006. We did a review back in 2014. Among 191 cases of our patients, majority had 46XY DSD, and at least 40% of them we did not have the definite diagnosis. So fortunately, since 2017, we were able to perform the targeted next generation sequencing using 47 genes, which the result is similar to the one that Dr. Hattori has shown to you, that the most common genes are AR and SRD5A2s. And also we have found mutations in WT1 and MAMLD1. So within my talk, I will focus on these 4 genes. So I'll start with the SRD5A2, which located in chromosome 2, and it's rather small gene comprised of only 5 exons. It encoded 5 alpha reductase type 2 enzyme, which is expressed in the prostate, seminal vesicle, epididymis, and liver, and it converts testosterone to DHT, which we all know that DHT is significant for the prostate gland growth and also for the differentiation of the male genitalia. This is the review paper by a team from Brazil, and it shows 121 variants in 451 cases of SRD5A2 from all over the world. And very interestingly, that they found that 70% of patients had homozygous mutation with the hotspot located in codon 196, 227, 235, and 246. However, among our patients, the hotspot is a little bit different. We found the hotspot in 227, 203, and codon 6. And compound heterozygous are much more common than the homozygous variant. All 3 variants that found in our cohort affect the enzyme activities from no enzyme activities to about the residual about 40% of the normal. Majority of patients were raised as male. And you can see that even with the same mutation, the phenotype can be variable. For example, with the compound heterozygous in the codon 203 and 227, the EMS score can range from 3 to 9, and also with the homozygous of variant in codon 227, the EMS score range from 3 to 7. However, there are certain variants, compound heterozygous, that have a little bit like my phenotype, which actually, I try to get the pointer, let's see, highlighter, laser? No? Can you see it? No. Oh, okay, thank you very much. I have been like talking without pointing anything, sorry about that. So with the variant in intron 3, and the codon 227 seem to have milder phenotype with the EMS score of 7. Unfortunately for this patient, that he become more virilized when he entered puberty with the penile length increase from 3.7 to 7.5 centimeters. And all of our patients were assigned male sex. Only one patient that had an EMS score of 3 were assigned female. And the only reason is that at that time, we did not find mutations. We found only one variant in this patient initially. So he was not diagnosed as alpha reductase type 2 deficiency, and the decision was he should be raised as female according to the families. So the gonadectomy was done at 11 months old. However, this is such a classic case of alpha reductase type 2 deficiency that the gender dysphoria is very common, even though the gonadectomy was done very early on. And at 15, she came in and said that I don't want to be a girl. This is a reveal that try to look at the genotype and phenotype correlation, and the authors divide the type of mutation according to the function. You can see that the one that affect the testosterone binding domain seem to have the most severe phenotype, with the EMS score range from 2 to 3, and also the one that affect the NADPH domain seem to have rather severe phenotype as well. However, the one that affect the enzymatic activities seem to have more phenotype variability, with the EMS score range from 3 to 8. Here is the pictures of our siblings with compound heterozygous mutation with the nonsense mutation at codon 6 and missense mutation at codon 227. You can see even with the same mutation, there are a little bit of the difference in terms of the phenotype, one with a bifid scrotum, one without, but very small penis. Unfortunately, in Thailand, we do not have the DHT cream. So to increase the size of the penis in order for be able to perform the uretroplasty, we have to give a lot of testosterone depot injection, and both of them require at least 6 shots to increase the size. So why there is not a strong genotype-phenotype correlation in SRD 5A2? Because there are possible explanations. First, there might be polymorphism in the AR gene in certain cases. And also, they have been found that even in the same siblings, there are different in terms of the phenotype. And as we all know, the DHT can be generated by the androgen backdoor pathway. So if the patient have difference in terms of the enzymatic coding for the androgen backdoor pathway, that will affect the phenotypes as well. So AR gene is quite big and contain of 8 exons and located on the X chromosome. And up to date, there are more than 900 mutations found. With the androgen receptor variants, it can be classified as complete, partial, or mild androgen insensitivity syndrome, depending on the residual activities of the AR function. With the complete loss of the function, it results in complete AIS, and most of the mutation found are located in the ligand binding domain, followed by in the exon 1. For partial AIS, most of the mutations are found in the ligand binding domain. For my AIS, it's predominantly occur in the trans-activating unit 5 in the N-terminal domain. So what is the clinical presentation? For the complete AIS, usually they came in because of primary amenorrhea or inguinal hernia. They have normal breast development. And one thing that for the fellows should know about this, that when you look at the breast, it can be like 10:05, but when you look at the pubic hair, there's no pubic hair there or no axillary hair. So that's a classic phenotype of complete AIS. They have blind ending vagina without uterus. For the hormonal profile, in puberty, they will show age-appropriate normal plasma testosterone, normal or elevated LH, normal or elevated estradiols. For partial AIS, the phenotype can range from mild hypospadias or micropenis until normal-looking female exogenitalia with clitoromegaly. And it depends on the residual activities of the AR. Another thing is that in puberty, they develop gynecomastia and they don't have much of hairs. For the MyARS, usually they do not have ambiguous genitalia as well, and they came in because of gynecomastia or male infertility, and it can be part of the diagnosis of Kennedy disease, which is bulbar and spinal muscular atrophy, which caused by the hyperexpansion of the CAG repeat at the level of exon 1 in the AR gene. This is the study from Cambridge looking at the correlation between genotype, phenotype, and sex of Rayleigh among 111 patients with partial AIS. And you can see that even with the same variant, the phenotype can be varied, like EMS score, like from 1 to 8. I'm going to show you a little bit of that. For example, the variant that affect the DNA binding domain can have very vary in terms of the phenotype. The one at codon 703 serine is changed to glycine, seem to have more severe phenotype, and one report of the complete ARS. On the other hand, the mutation at codon 840, arginine is changed to cysteine. There are more phenotype variability, the MS score ranging from 2 to 11, and you can see that even with the same family members, the sex of Rayleigh can be different as well. So what can cause the genotype-phenotype incongruence among the AR variants? There are many factors. It can be that the level of alpha reductase type 2 deficiency are different because of their polymorphisms. And in rare case, AR mutation can present as mosaicism. There might be other co-regulators that regulate the AR function. And also, as we all know, that the oligogenicity might definitely play a role in the phenotype variations. In our 16 patients, most of the variants are located in the ligand binding domain. There are 5 patients that have variants in the N-terminal domain or DNA binding domain. And 2 of them presented with complete ARS. The first one presented at 16 with primary amenorrhea. She had normal breast development, no axillary hair, and you can see that she had elevated testosterone level and LH levels, and she got a gonadectomy done at 17 years old. The others were raised, the other 3 patients had partial AIS. Okay, so another 11 patients with variants in the ligand binding domains. 2 patients presented with complete androgen insensitivity syndrome. 1 presented with primary amenorrhea and abdominal mass, and the other one presented with bilateral inguinal mass. In our cohort, all the partial androgen insensitive syndrome cases, except 1, were assigned male sex. Only 1 that had EMS score of 3 were assigned female sex. And when you look at the literature, I think there are quite big difference in terms of the sex of rallying. It can be 50-50 or predominantly male. I think it depends on the ethnic and social cultures as well. One thing to be noted is that all of the male sex partial AIS cases, when they enter puberty, they came in with gynecomastia. And unfortunately, many of them still have very small size of penis, which is very frustrating for the patients. I just want to talk a little bit about this patient with complete ARS who came in at 49 years old with huge abdominal mass, and she had normal breast development, no pubic hair. She had primary amenorrhea. She got married and then consult the infertility unit because she couldn't have a kid, and turned out that she had 46XY, but then she lost to follow-up, and she came back again at the age of 49, and it turned out that she had large serous borderline tumor. Luckily, it wasn't gonadoblastoma. It's a tumor that arrived from paragonadal soft tissue. So, and I want you to look at her hormonal level. This is very typical for patients with complete AIS. Okay, so I have only 9 minutes left, another 2 genes to go. The UT1 is located on chromosome 11 and very important in regulated differentiation and survival of the cell in several organs, especially kidney, gonads, nervous system, and heart. And it contain 10 exons, and there are 2 alternative splicing sites. The splicing site 2, which encoded by exon 9, can give rise to the isoform with or without KTS. And this is very important because the isoform with the different ratio of the KTS positive or negative influence the gonadal development and the phenotypes. In terms of the phenotype of the gonadal development can range from normal testes to complete gonadogenesis. And there are certain variants that probably have a very unique phenotype. For example, the Dennis-Drash syndrome, most of the variants are located in exon 8 and 9, and Dennis-Drash syndrome presented with congenital nephrotic syndrome or early onset rapidly progressive steroid-resistant nephrotic syndrome. If you do the renal biopsy, it shows diffuse mesangial sclerosis. They progress to end-stage kidney disease very rapidly. They are high risk of Wilms tumor. In terms of the gonads development, usually the patient have partial gonadal dysgenesis. And I want to show you one patient who came in with infantile nephrotic syndrome. However, her renal biopsy showed focal segmental glomerulosclerosis, and she turned into end-stage renal disease at the age of 7. She received a cadaveric kidney transplant, and at 13 years of age, she was found to have a pelvic mass with elevated beta HCG. So it turned out that she got the gonadoblastoma with this germinoma. So what does she have? What is the diagnosis? So she got Fleischer syndrome. She had karyotype of 46XY, and she had normal external female genitalia. And the variant was found at the splicing site 2 in intron 9, which is one of the most common hotspot for Fleischer syndrome. Why this type of mutation caused Fleischer syndrome? Because the positive KTS isoform appear to be more efficient in activating the SRY promoter with the decrease in the expression of the KTS positive isoform, it affects the fertilized cell maturation and their ability to support the germ cell differentiation. So that might cause the risk of gonadоblastoma later on. And normally with the Fleischer syndrome, patients present with later onset of nephrotic syndrome and had slower progression into end-stage renal disease. However, our patient is quite different. So you can see that with WT1, there's broad spectrum of the phenotype and clinical presentation. Another patient that we have present with delayed puberty, and she had Wilms tumor at the age of 1.5. She had primary gonadal failure, and she was found to have variants in a nonsense mutation at codon 463. And when we look at the literature, we found that these variants are the hotspot for the non-syndromic Wilms tumor. So there are more varieties of the WT1 mutation than is Drash or Fleischer syndrome. It can cause non-syndromic Wilms tumor, and also it can cause just the 46XY DSD without the kidney problems. As I showed you here, that we found 3 novel heterozygous variants in 3 of our patients. All of them did not have Wilms tumor or kidney problems, but they presented with pinoscrotal hypospadias, no micropresia, and they had normal Leydig cell function to begin with, but one of them shows some degree of satellite dysfunction at the age of 15, and one had atrophic left testis, and the other one had one strict testis, so compatible with partial gonadal dysgenesis. My last gene that I'll focus will be MAMLD1, and MAMLD1 actually we don't know much about the function of it, but it's predominantly expressed in the human fetal and adult testes and also in the ovaries. And it possible has an important role in testicular function during the prenatal period and possible also in the afterbirth period. It has been shown that hemizygous pathogenic variants of MAMLD1 cause 46XY DSD, and this slide shows the genomic structure and the genes found in MAMLD1. There are a wide range of the phenotype presentation, but probably the most common one is the isolated hypospadias. However, micropenis, bilateral undescended testes, or even complete gonadal dysgenesis have been reported. Majority of patients had normal testosterone production during the infancy or childhood and no mammalian duct derivatives. There are debates whether MAMLD1 really is the sole cause of DSD. Why is that? Because in many variants that have been reported, some of them show preserved trans-activating activities in the functional studies. And even with the same variants in the same family, they have different phenotype. Some variants that has been shown to cause the disease have been found in general populations. So there's still debate about that. And there's a nice study done by Krista Fluke and her team. She did the whole exome sequencing in 746XY and 146XX patient with MAM-LD1 and found another 55 variants in 41 DSD-related genes, and 23 of them interact with MAM-LD1. So with this paper, it showed that possibly that with the MAM-LD1 variants, there are at least part of the oligogenicities from other genes that affect the phenotypes. So I just want to show you that our patient, the half sibling with the frameshift mutation of MAM-LD1, both of them present with pinoscrotal hypospadias. Micropenis very tiny. One had only 0.8 centimeters at birth. No Mauryan duct structures. They have normal testosterone production, and they enter puberty normally. And we have been following them up until now. They're about 18 years of age, and they haven't shown any sign of Leydig cell or satellite cell dysfunction. So in our case, since they are the same family members, it's possible that with this type of mutation might be the sole cause of their DSD. So in conclusion, there are no definite genotype-phenotype correlation in 46XY DSD caused by AR or SRD5A2. WT1 variants can cause varieties of phenotypes, and it's a very interesting gene to study. And some of them can have normal Leydig cell function initially, which might lead to a misdiagnosis as a DSD with normal Leydig cell function, and you might think that they might have the SRD5A2 or AIS. So in terms of diagnosis, the molecular diagnosis is really important to answer that question. And MAM-LD1 is another etiology of 46XY DSD, and maybe the oligogenicity play a role in their phenotypes. So we don't know. I think there are some knowledge there that show that why there are incongruence between genotype and phenotype in certain genes, but we still need to have further study to understand more, because there might be other genes or other factors. Lastly, I would like to acknowledge all my Intersect Care team and the molecular analysis team at the Sierra Hospital, Faculty of Medicine, and for giving the funding to do all the next generation sequencing. And lastly, thank you very much for the PACE and ESPAIR scientific committee and the local committee for giving me the opportunity. And thank you for the wonderful hospitality. Thank you very much.
Thank you for Gerunda for your nice talk. And we are a little bit behind the schedule, but if it's possible, I'd like to take some small questions, one or two about the genetics talk by Dr. Hattori and Gerunda. Any questions or the comments about their talks? Yeah, Dr. Paul, please.
Thank you very much. But can I say they're both wonderful talks? Thank you. Very clear. Dr. Hattori, yes. You talk about over-testicular DSD. The fact you get ovarian and testicular tissue in the same gonad, is that due to a change in the activity of SOX9 or of SRY through the gonad, or is there a particular reason why you get a change from ovarian tissue to testicular tissue? Can you explain that for me?
Your question is why ovotestis occurs?
Exactly, rather than a street gonad or an ovary or a testis, why are you getting one end ovary when the other pole a testis? Is that related in your SOX9 case to increased activity at one end versus the other, or is there some other explanation? Do you know?
Thank you for your important question. It is my speculation, but the testis, sex differentiation of gonads is stochastic event, so it can fluctuate, and SOX9 expression levels, if it exceed the levels of thresholds, it would be upregulates its own genes, so it can go either way. It can fluctuate. So at some part of the gonads, it can go to the ovary, and the other part, it can go to testis. And that's why I think that's why ovarian tissues and testicular tissues can coexist in the same gonads.
Yeah, I think that the SOX9 regulation is a kind of positive regulation, positive feedback regulation. So some differences of SOX9 functional changes will cause a very fluctuated result, I think. So his answer may be like that. Is that correct?
Thank you very much.
Thank you. So next question, please.
Not a question really, but a comment. I think both the talks were very, very useful. I'm Dr. Vandana Jain. I'm from All India Institute of Medical Sciences, Delhi. So we had also done a genetic workup in a cohort of 150 children with 46XY DSD, mostly from northern part of the country, India. So we found that SRD5A2 was the commonest gene in 25 out of these 150 children with XY-DSD. And in these 25, out of these 15 had one hotspot, which is R246Q. So you also showed it is one of the hotspots, but in India, yes. So it was like 60% of the children had this one particular hotspot, but there was no genotype-phenotype correlation at all. So the EMS score ranged from this children with the same hotspot from 0 to 8.5. So it was very variable. The other thing we found was that T to DHT ratio did not really discriminate between SRD5A2 and partial androgen insensitivity. So in almost all the cases of proven AR gene mutation also, the T to DHT...
Sorry, your question please more simple and briefly, it's okay.
Able to look for DHX37. So I think that is a very, very important presentation that you made, that in children without Mullerian structure and with gonadal dysgenesis, one should look for these. So I think if we have such children, we should look for that particular gene also. Thank you.
Okay, thank you. Your comment. Thank you. Comments.
Can I say something? It's very important that actually, even in this Asia Pacific region, the hotspot can be varied. And I think I came up with your paper that the 246 is the hotspot in your cohort. But however, we did not find that in the Thai cohort at all. And we found the similar things, that the testosterone to DHT ratio cannot be used. And there are varieties. There are more varieties. Yeah.
Okay, thank you, Jarinda. So we would like to move to the next talk. Thank you for Dr. Hattori and Jarinda.
It's for the next two talks, both bordering upon sex of rearing decisions. It's a pleasure to invite the first speaker, Professor Minu Bajpai. Professor Bajpai is the former head of department of the pediatric surgery department in All India Institute, Delhi. He's been a teacher to generations of pediatric surgeons who have trained in all the expertise which Dr. Bajpai has generated in his department. He also was the dean, academic dean in All India Institute, and in charge of international collaborations and many MOUs in All India Institute. He has made great contributions in pediatric surgery and pediatric urology, including in recent times minimal access surgery. In order to expedite patient recovery. Dr. Minu Bajpai will speak.
Thank you.
On genitoplasty for CAH, management, sociocultural, and legal issues. I just want to mention that the second talk will come after Dr. Bajpayee's talk, and then the question time will be a common question time. Please, Dr. Bajpayee.
Thank you very much. Good morning. I would like to thank the organizing committee members, especially my esteemed colleagues, Professor Vijay Lakshmi and Professor Rajesh Khatgawat, for inviting me for this interesting talk. I would not talk about the surgical techniques of genitoplasty, but rather I would discuss the change paradigm to how we approach the management of these children. So you can see the first slide shows the clinic in which we worked. I worked at the Institute for 38 years. The data are from its inception in 1981. And I could see a preponderance of 46XY DSD, almost twice that of CAH, which is a departure from what you see from the data from West. And it reflects the social milieu of our countries. I can say for sure about India, Pakistan, Turkey, and many such countries around. The patients were drawn from the rest of the country, many states. Again, I can tell you that these states vary in their language, cuisine, climate, but their emotion for a child with DSD is uniformly almost the same. Good thing is it is slowly changing, and people are getting more enlightened and more careful about their kids. Now, as I mentioned, gender assignment and socio-cultural influences go hand in hand, where traditionally the gender assignment was based upon the influence from sex of rearing, and the treatment was dependent upon the size of the phallus. And it still holds true, not only in the villages and remote areas of our country, but also in the West. And these are the data from the German Intersex Support Group. It is now being increasingly realized that gender identity is a result of complex interaction between genes and environment, and it is hugely changing, especially more and more cases of gender dysphoria are now coming up, so which is again a notable change. And it is impossible with great certainty to predict what gender a child would later on come to identify with, and that's where gender dysphoria component. Now, there was a time in the 80s when we used to discuss about the techniques of genitoplasty and the results. It is changing now. We discuss now the paradigm shift which has taken place, the approaches, the emotions which go when the parents see a child with that, and a group of very concerned people, advocacy group, which can also be shortly called as health activists, who are also equally concerned about the patients. So we have three stakeholders. There's an interaction between shared decision making between parents and the surgeons and the clinicians overall, with the backdrop of keeping in mind that we have other considerations also. So if we look at them one by one, parents' strong wish to surgically normalize their child's sexual anatomy. It has been traditionally there, it is still there. They view genital surgery as obvious and necessary to assure their child's positive psychosocial and psychosexual adaptation. Follow-up studies suggest predominantly favorable attitudes towards early feminizing genitoplasty, thanks to some of the wonderful studies, some of them I will quote soon, which have actually come to the rescue of these children who later on suffer. And therefore, some of these studies are seminal, and I'll discuss them in detail very soon. There is an interaction between parents and the healthcare providers who help interpret test results, anatomy and physiology, hormone production, hormone receptors, gross anatomy. They inform parents' decision about gender assignment. Individual cases are referred to institute subcommittee, ethics, main committee, and if there are difficulties in decision making, it goes to the family court. And this particular data has come from Australia. Huge, great work done by Dr. Gary Brown for years by working in many parts of our region. So surgeons look at the benefits the patients physically and psychosocially by surgery. So they have realized now that atypically developed genitalia affect physical appearance, body image, function of the urinary tract, gonads, and psychological and psychosexual development. So saying that therapeutic options only help in cosmetic improvement is not totally true, barring one condition which I'll come to. It affects the function, it affects overall milieu, the emotion, the development of the child. So surgery has an important role to play. It's just not a technique to be offered. Now, clitoroplasty is offered, and even the activists agree that there are emergency situations when it could be offered. For example, in CAH, to create unobstructed outlets for urine. If you have a long urogenital sinus, there could be backwash, infection, and stasis. Therefore, that's one. Early clitoral reduction surgery, definitely, I was alluding to that earlier. Mild clitoromegaly could be classified as one where it's cosmetic surgery, and that's where we talk to parents about it, and that it is just a variation. And it has issues which may impinge upon their tissue sensitivity. Surgery is recommended for severe clitoromegaly. There have been a pendulum swung, but finally it has come to a more stationary state now. Clitoromegaly, which is severe, should be offered surgery. The main question is when to offer surgery. And for that, I was alluding to an article, which is a wonderful article. I'm going to come to that. So this activist platform has actually emerged out of things which happened when the data were analyzed, that some kids were harmed. The sensitivity of the local tissues and some complications of surgery were blown out of proportion. And nevertheless, why should there be even one case which would go wrong? But that led to a ball sort of swinging down. So the concerns were parents seek to act before becoming fully informed of all the options. So there should be a shared decision making with deep dive into what all is the spectrum. And that's where we have come to the understanding when we talk to our parents and children. Legal and ethical questions, patient autonomy, deferral of decision, to what extent, to the legal age, and that's again has been answered by this study. Comparative outcome associated with performing surgery later in life versus early childhood. So which led to, unfortunately, a general moratorium. We all realize, and we have grown in medicine as students, as practitioners, there is nothing 100% in medicine. And so there are variations, and we deal with individual cases. We are now into the stage of personalized medicine using the technology of artificial intelligence and machine learning. So therefore, a moratorium is generally not accepted. Whether, now this particular article, whether later surgery has better, poorer, or comparable physical, psychosocial, and psychosexual outcomes. So this particular study group, DSD Life, a multi-center cross-sectional clinical evaluation study with 16 partners, 14 recruiting centers across Europe and the UK, came out with some very important data. The group of patients were adolescents more than 16 years and adults with DSD, conforming to the Chicago Consensus of 2006. Interviews, retrospective charts, and medical examination was conducted. Patient-reported outcome questionnaire were given to them, and these questions were like this. Should there be a general postponement of surgical intervention until legal age? Half the patient disagreed with this statement. 25% agreed, 1/4 didn't know. What is the appropriate time for genital surgery? 46% agreed for infancy. And they were the adults. They were happy it was done at infancy. 20% between 4 and 12 years of age, all children. So almost 2/3 agreed it should be done in childhood. Should clitoral reduction be necessary in girls? 38% agreed, 14% disagreed, 18% undecided, 29% don't know. And obviously this is very sensitive question, and we can see this variation of answer. Vaginoplasty in adolescence, adulthood, or infancy, 2/3 approved of surgery in infancy or childhood. So these were adults who had gone through this, and the data emerged from whether it should be done in early childhood or later on, and that's what we have now. So these data suggest that congenital adrenal hyperplasia persons predominantly favor interventions in childhood. A moratorium, one for all solution is not justified. Case by case decision making is better suited. Efforts in improving information on long-term outcomes should be carried out. We learn every day, and therefore we should continue to look for answers together. Shared decision making gives us answers and more questions also. So therefore the three stakeholders, the advocates, the clinicians, and the parents, the data which emerges out of this interaction should be looked forward, and we should be more and more informed. And we should maintain contact with support groups. If there is considerable uncertainty which happens in day-to-day practice, we should motivate parents to postpone elective genital surgery. And we come across these situations, and we should not be very dogmatic. From the European Society for Pediatric Urology and the Society for Pediatric Urology standpoint, medical and surgical management aims at avoiding potential health hazards, anatomy and function of the urogenital tracts. We should meet parents' expectations. We should help individuals' future satisfactory sexual function, which should be consistent with their gender identity. So therefore, shared decision-making, a multidisciplinary approach. So in the clinician group, we have subspecialists along with the advocates and the parents. We should provide explicit knowledge that a decision is required. Evidence concerning the risk and benefit of each option should be discussed in detail with the family. Process takes into account the patient's values and preferences, and these are socio-economically, structurally, region-wise variations. A huge amount of input is required, and that's what shared decision-making is. So the steps are inclusion of subspecialists. There are 6 steps. Involve parents in decision-making. Parents need help addressing the emotional feeling. They get carried away. And then we should identify, here is a family which is too much disturbed. We should give them enough time to come down by giving them proper data. Avoidance of terms referring to genitals. Providers should strive for objectivity, evidence-based information available, hard data to convince them, to show them, to understand. Parents should have received unbiased information, hopefully leading to a consensus based on trust and understanding. So we are facing this every day now with the changes which are happening. These paradigm shifts have led us to sit down and think what kind of surgery are going to be offering to these kids. It was not straightforward surgery. Now all this goes into this. There are legal issues. To ensure that the consent is truly informed, it has to be qualified and persistent. It should be in writing. The information provided must be complete. The parents must be informed about the dangers of current treatments, the possibility of delaying surgeries and giving adequate psychological support to the child. The authorization must be given on several occasions. Give them enough time to understand. They come back. We ask them to come back after 6 months, even if they've understood, so that at least it seeps down, and they may come back with the same answer. So a reasonable time should be given to them. Thank you very much.
Thank you, Professor Bajpai. You have please kindly, would you like to take your seat here while we invite Professor Kanishka Das? You have beautifully brought out the dilemmas which haunt us every day in our patient care. It's a privilege to introduce Professor Kanishka Das. He also started his career at All India Institute of Medical Sciences, but then moved south and spent a large part of his career in St. John's Medical College in Bangalore. And then recently he has moved to Eastern India. He's heading the Department of Pediatric Surgery in All India Institute, Bhubaneswar. Professor Das's area of expertise and interest are pediatric urology, Hirschsprung disease, and spinal dysraphism. We chose 2 eminent speakers bringing their thoughts from different parts of our diverse country. Professor Das will speak on surgical management of XY DSD and gonadal dysgenesis. Professor Das, please.
Thank you. It's a pleasure to speak in this forum before an august audience. I am grateful to the organizers for giving us this opportunity, and I also represent the Society for Children with DSD. I'm the secretary of that society. My brief would be to go through this big burning question that is on across the world: early versus late surgery, if at all surgery in DSD. And I would restrict myself to 46XY DSD and gonadal dysgenesis. So to be or not to be is the question indeed. Yes, as Sir has already outlined, surgical intervention must benefit the child both physically and psychologically. And of course, in an utopic situation, that is what we look at. It should be not just cosmesis, but functionality and taking the psychosexual orientation and disposition into account. It's a very emotive aspect. Everyone, all the three stakeholders get agitated over this often, and many rounds of counseling are required to come to a point of concurrence where it should be done or not. Unfortunately, there's a very weak evidence base that we have, and you really can't hit at evidence-based medicine to go about discussing these points for surgery in DSD. And there is a lot that comes into play: questions of normality, personal experiences of the children, and the expectations that both the parents, child, and society have. Broadly, the surgical interventions are these: reconstruction of the external genital tissue. This is something which comes immediate, like a cordy correction in early childhood, or a hypospadias repair, or an occipopexy, which has to be done to prevent problems with the abdominal testis and undescended testis. Repaired related to the obstruction of the Mullerian structures or its effects on obstructing the urinary tract, like a vaginostomy, which we do occasionally. Gonadal removal or pexy elsewhere, primary to eliminate the tumor risk and avoid contrasexual puberty, and others. Many of these are diagnostic before we move on to the more therapeutic procedures. But whatever it is, it requires an examination and anesthesia, because in the OPD, we really can't make much of the anatomy that would lead us to plan a surgical intervention or not. So these are very carefully selected and scheduled so that they're clubbed together and we don't have much exposure to anesthesia and minimize anesthetic harm. A lot of diagnosis depends on endoscopy, genitoscopy, laparoscopy, and a gonadal biopsy in certain instances. The therapeutic procedures are those listed there, related to the gonad, gonadopexy or gonadectomy, that is in sharp focus, as you would see later. Dealing with the Mullerian structure in dysgenesis or in ovotesticular DSD, either its division, its removal, or its preservation, depending on what we plan to have the treatment as. Dealing with the urogenital sinus remnant in 46XY DSD, and genitoplasty. Breast surgery is something which is kept for the later part at puberty. So the surgery for XY DSD and gonadal dysgenesis is what we will move to now. Briefly, I will deal with the testosterone biosynthetic defects, the conversion defects. These are a special group of defects which must be recognized early, because we know that these virilize at puberty and can cause a lot of problems if they are not detected early and managed early in the correct manner. We would avoid a lot of gender dysphoria in these children if they're detected early and suitably managed. Androgen insensitivity, which is again a big group, a heterogeneous group, the complete and the partial types, and the minimal type. Of course, here what is overriding is the what to do with the gonads. Can they be pexed? Can they be removed? Because we know that they have different rates of malignancy. Then the second group would be gonadal dysgenesis. The shades of gonadal dysgenesis, it can vary from the complete to the partial to the mixed being the commoner one that we see. And here, dealing with the Mullerian remnant and dealing with the gonad, which has a much higher incidence of malignancy. The crux of the matter: what is it that we have against early surgery, or the world has currently against early surgery? We are all very familiar with the voice of the American Medical Association, which says that you respect patient autonomy, bodily autonomy, and preserve all options till the child can decide. Now, the time that the child can decide is still in sharp focus, and we really do not know when that is. But of course, it fosters a shared decision making with all the three participants, the parents, the children, and the healthcare provider in tandem. And there is a certain shift from paternalism to a patient centered shared decision making with partial or full disclosure. So, this right to an open future and a fluidity in gender choices is what the current thinking is about, and hence a moratorium from many advocacy groups to defer all major reconstructive surgery and irreversible surgical interventions to a later date. Of course, it is important to outline surgically what are the goals of the patient in surgical care. Not all of them would have the goals that we presume that they would have. For example, not all would want to have penetrative sexual intercourse. This has come out in the interviews with many of them, when the surgical goals of the provider was different from that expectations of the patient. What else is against general early surgery? Does it really address the primary driving factors? Early surgery was touted that it would sort of take off the parental shame, anxiety. It would offer a quick fix to normalize the child's appearance. But then, does it really do that? Or is it that you're jumping into something without being fully informed about the risks and benefits? This is the argument that is put forth. And there are reports of unfavorable outcomes, complications, like in any surgery. When you have early surgery, it's too early, and there is very little tissue for the surgeon to work on and reconstruct, especially in feminizing genitoplasty. If you dispose of tissue, you're left with little at puberty to work on. Gonadectomy, of course, under a strong focus, because you have not just loss of hormones, but also the fertility potential is thwarted. And of course, anesthetic harm. But is there a case for early surgery? There certainly is. There certainly is in many of our socio-cultural contexts where we don't seem to have a cultural space for a third gender or a non-binary assignment. It is spread over the world, may not be so much in the West, in some countries, but certainly in a large part of the third world. People are yet to come to terms that you can have a childhood of ambiguous genital anatomy. Even if you have considerable parental support, social support is not always forthcoming. It is not just a question of somatic issues, question of standing up and voiding, not having a cordy, or not having a hydrometrocolpos, retained secretion, hydronephrosis. It's not these immediate precipitant issues, but it is also social issues of prejudice, social reactions against the child, the family, how they have to meander through society, and often a cause of parental rift and divorce, especially in India. So they say that it's a social experiment to think so, and probably not reflective of what we should be doing in the third world. This is just a picture to remind us that there is such a variable anatomy, even with a similar sort of genotype or a biochemical assay, etc. And we know that you really can't move around in society. Many of them will not be able to move around in society with this unless some issues are addressed. Also, what else is for early surgery? Whatever psychologists say, they also agree that the gender identity, we do not know when it develops. We are led to believe that it develops by 2 to 3 years, but probably later. But maybe it requires a good sexual identity already priori to be able to build on it. And what do we do about self-initiated gender assignment or reassignment? What answer do we have for that? Late surgery again leaves too little tissue for the age at puberty. And of course, advocacy groups are still quarreling amongst themselves and they are not concurring on several points, including whether CH should be included at all as a DSD or not. The literature that we have is old, it is heterogeneous, and you do not have a solid research data there on many issues. Now, when can a child make decision about genital surgery? There are large gaps in our evidence that we have. There is no clear evidence base, and it adds to a condition where you have a rare condition, you have a heterogeneous condition, you do not have a registry, you do not have adequate follow-up. So what really are you backing on to make these strong statements? Several current studies also show a low sex reassignment rate, like the DSD Life study, which was quoted, and it seems that early surgery has worked well for those populations. So, should adult patients who are dissatisfied really dictate terms? Going on to masculinizing genitoplasty, this is relatively uncomplicated and staged. It's done in a sequence: corti correction, occipitopexy, urethroplasty, repair of penoscrotal transposition, and so on. There is a clear timing in the first or second year of life. We know we don't leave the undescended testes high up, and so on. The question of gonadopexy and gonadectomy, we will come a little later. That is etiology specific, and breast surgery is done at puberty. Longitudinal follow-up shows that they're better satisfied, and there have been many content adolescents and young adults with early surgery. There have been problems like anejaculation, lower fertility outcomes, and so on. So just to illustrate, a persistent Mullerian duct which needs to be removed there, and the two intra-abdominal gonads which need to be pexed. Now, genitoplasty, the urethroplasty in proximal hypospadias is a technically demanding job, penoscrotal transposition. We have gone through the DSD Life studies, so that is the range of the study: 150 patients, 84 hypospadias surgery, and they were all early childhood surgery. They were generally satisfied with function than cosmesis. Of course, PAIS is singled out as the single one where results were not so favorable, and that was a marker for poor results. Going to the androgen insensitivities, it's a common form as discussed earlier. Here the question is that there is a risk of tumors is negligible before puberty. Those are the general risks, 0.8 to 2%. So it is beneficial to resite it because there are popping gonads coming into the groin, and it can be left there for conversion and pubertal estrogen production, and it can be removed at puberty. That is the current consensus. Of course, there's extensive patient education which is required, and vaginal surgery for these is best postponed for puberty. Example of androgen insensitivity with the gonads being removed at puberty. Here there's already a vagina which mostly requires a dilatation and may not require a surgery. In partial androgen insensitivity, it is a little different. The gonads are in the groin, you have a greater genital ambiguity. There can be a problem with the vaginal pouchitis, it may need to be addressed. And the gynecomastia again would be treated at puberty. The ones which are read as females, an early gonadectomy is done to avert virilization and development of malignancy. The chances here are higher, it's 2 to 5%, and there are in situ changes which cannot be detected radiologically. And the neoplasms are a broad range from choriocarcinoma to Sertoli cell adenomas and Leydig cell tumors. So here the risks are different from complete androgen insensitivity. The most frightening group is, of course, the dysgenesis. It's a spectrum, a wide spectrum, the mixed gonadal dysgenesis being the prototype. They have varying secretory or generative function, so the gonads also cannot be judged at face value, but they have a significant malignant risk, and they need to be either removed early, or if they are retained, they have to be monitored very carefully. They can be relocated to the groin and the scrotal folds for monitoring. Very often we have a gonad which is streak on one side and probably normal on the other side, but this normal one also needs to be monitored. Bilateral streak gonads, which gonadoblastoma as early as the second year of life. The streak gonads can be very deceptive and they need to be carefully examined histopathologically, and the descended gonad also is kept under surveillance. The risk is prohibitively high, 30 to 50%, especially if the Y chromosome is there and it's intra-abdominal. There can be CIS right from the 3rd month of age, in situ, and mature to a germ cell tumor by a year of age. Risk increases, especially post-pubertal. Gonadal biopsy is a very tricky thing here, and the entire gonad has to be seen carefully. Just a simple biopsy may not help, and you might miss it. There's a mismatch between the macroscopy and the microscopy, and we have immunohistochemistry now with markers to particularly help us differentiate it from maturation delay and pick up the in situ lesions. Up panel is a picture of a gonadoblastoma, which has developed very early in a streak gonad, And the lower picture is picture of many in situ lesions as early as the first year of life. The different tumor rate stratification, the highest being for gonadal dysgenesis and the lowest being for complete androgen insensitivity. So there is a stratification where you go in for dysgenesis, early gonadectomy, early or late. Kuhl believes that it is can be based on the EMS. In a female phenotype, an elective gonadectomy is advised. A more undifferentiated gonad is more likely to harbor a tumor. The mild undervirilization you can PEX and wait for surveillance. A similar thought is also expressed by Wolf and Buttel et al. Finally, it's its secretion, a balance of that, compliance with surveillance and patient preference. This would be my last slide. So has already outlined the principles of deferred surgical management based on shared decision making. However, there is a lack of evidence base, and that is a hindrance to a deferred surgical intervention. Yet, we are obliged to provide them with decision support tools. These are extremely important in a multidisciplinary clinic and careful surveillance and treatment planning. And we certainly need to develop new management algorithms to ensure the long-term health, not just of the genital tract, but also of the urinary tract and the safety of this retained gonads. Thank you.
Thank you, Professor Das. Yes, please take your seat with Professor Bajpai.
Jarinder?
Suchit, may we have some time for two, three questions?
Take a couple of questions.
Yes. So we can take up some questions for all the speakers. May I start off, please?
Before we take up the question, can I ask a question to Dr. Hattori here?
Then you're eating into your own question time.
So this is not working. So.
Please pass on a mic, Suchit.
Yeah. So
Yeah.
if there's any
Actually,
question, let us first handle that. Yeah. Thank you.
Am I?
Yes, Dr. Menon.
Dr. Pearson Menon from New Delhi. Thank you, Professor Vajpayee and Professor Kanishka Das, for an interesting highlights about the current management protocols for both 46XX as well as 46XY DSD in your long experience. Despite the experience of the surgeons and the DSD teams managing these children, we are essentially under the control of the Government of India guidelines as recently as the June 2024 guidelines. And I think we are bound to follow these guidelines despite what is the considered opinion of the patient management committee or the medical board constituted by the ethics committee. There are many controversial situations that happens. So how do you decide that despite the advocates groups, because the advocate groups are essentially pointing towards late or postponing surgery as much as possible, whereas many parents are not on the advocate side. They want actually an early surgery before the child goes to a daycare center or the school, where the child has to independently manage passing urine or other activities. So how do you go about
yes,
it?
so we can pass on the question because your question is quite clear.
Professor Menon, my teacher at All India Institute of Medical Sciences, in fact, he started off endocrinology. Sir, you have very rightly pointed out that despite all the regulations and everything, the moratorium part is weighing very heavily on us. It has a strong political overtones. This is very difficult to tide over. The only way to tide over this would be in the best interest of the children to collect enough data. The data that we were talking about through a very meticulous, prolonged, procrastinated effort by all stakeholders, recording data from the parents, the clinicians, and the involving support groups. I won't say activists. I mean, they are people who are advocates. They have got concerns. We have to provide them hard data, objective data to convince them. Therefore, it will be a long drawn process. And I don't want to make any off-the-cuff comment to say that recently there has been a sub judice matter, so I'm not going to detail. In Tamil Nadu, there was a moratorium. The pediatric surgeons there are running helter-skelter because we did everything, right up to the government, as you said, sir. We could not change it. Therefore, these are difficult times. We have to be careful. We have to see case by case. And I'm sure when we discuss with the families, etc., we see severe virilization, we are able to offer. The difficulty is cases where we don't have much problem when you have surgical problems which can jeopardize urinary tract for that matter. We can go ahead, we can convince, document. But in between the gray zones, we have to see case by case. I think at this point, that's where we are.
Thank you, sir. Dr. Bajpai, you said you had a question for Dr. Hattori. Please go ahead.
Thank you very much. So, Dr. Hattori, you mentioned a very interesting observation. And in pure gonadal dysgenesis, the incidence of malignancy is there when you have a Y line, not when there is no Y line. So, removal of that gonad depends heavily upon whether that Y line is present or not. And you mentioned that often it is difficult to get the Y line in over-testicular DSD. So, this is a challenge. How do you overcome this? And I'm sure we won't have ready answers to this, but what are you doing to find it out? Malignancy is very high. When the Y line is there in pure gonadal dysgenesis, there are two subvarieties, presence of Y line and non-presence of Y line. Y line has a very high incidence of malignancy. They should be removed. So you said that there is a challenge in getting the Y line detected in over-testis. So what tools do you use to detect it? And if you don't, what all do you do?
I think
SRY. That's right.
And over-testis.
You mentioned. One of you mentioned.
I think he means that how to detect the SRY gene. But yeah, I think you can do that. PCR.
No, it's a PCR of SRY is performed, and if the band is detected, the SRY is there. And another way to find it is G-banding can fish. Fish is sometimes fish is a good way to find it, and also RACGH can be one of the options.
That's the only way.
Can I add something? At our institute, all the 46XX over testicular DSD or 46XX testicular DSD we will perform FISH for SRY first, and if we couldn't find that, so we go for other genes in the next generation sequencing.
Even in XY, you do that?
In actually we do next generation for all both XX and XY DSD. But for the XX over testicular DSD, we started with looking at is there any SRY translocation by performing a FISH study for that.
Good, thank you.
Can I ask a quick question?
I'm afraid we have only time for one more question. That's what Suchit has indicated.
Good morning, I'm Dr. Subroto Dev from Kolkata, Apollo. I have a question to this esteemed panel. What happens with the XX severely virilized Prader 5 baby who later adopts a gender identity of male and refuses to play with his sisters and identifies himself as a male and plays with his brothers. Age 8, and the uterus was discovered after multiple MRIs much later, is a CAH, which has been proven. Both
Subrato?
biochemically.
Dr. Subrato, can you just
So
be brief and just ask your question?
No, it's very important to give the background because the question is, what should we do now since the child is 8 years old, is genotypically a female, and will go into female puberty? Should we allow that to happen when the parents want this child to be raised as a male, and so does the child? What's your answer?
Well, I think we have to take into cognizance the sentiments of the child. Now he's an adult, and or she, and the family. So we have to just respect that part of it. And the gender of rearing has been the predominant thing. We should just go by synchronizing everything which is there. You have no other option. It will have very devastating psychological impact if you want to do anything otherwise.
Thank you. So we should go ahead with a gonadectomy and a removal of Mullerian structures.
Whatever it comes.
Thank you. Thank you.
I'm afraid we have to stop this session. I myself want to ask some surgical questions, but I think all of us will interact with the speakers during the tea break. So thank you very, very much, all four of you, for wonderful talks. Over to Suchit.
Thank you, speakers and esteemed chairperson, for such an informative and good discussion. I request Dr. Vijay